Well, I think it was a very stimulating morning with the panel and also with Sid Zissok's presentation. And I'm looking forward to this afternoon, which I think is going to be equally stimulating. We're next going to hear a lecture from John Jordan, or Jack, as we know him. And Jack is the expert when it comes to bereavement after suicide, having published multiple papers and several recent books. He's a prolific writer. And again, one of the reasons that I invited Jack, as I did Sid, is that they are both expert clinicians, and so they aren't just talking about p-values at all, although they can. So I'd like, it's a pleasure to have Jack here. Jack?
Thank you. Thank you, Ted. It is a pleasure to be here. Sid was commenting on how it's difficult to follow Ted, and then I have to follow Ted and Sid after lunch, okay, and I'm still on East Coast time. I think I'm going to need some restorative napping, by the time this is about the time East Coast-wise that I would be taking my afternoon nap. So just kick me or something, Ted, if I seem to nod off. Let me tell you briefly something about myself and then give you a context for this. I appreciate Ted saying that I'm an expert clinician, but the clinical part of what I'm going to talk about is really happening tomorrow. And I will tell you briefly about, put in a plug for the training tomorrow, but I'm not going to talk directly about clinical work with suicide loss survivors in this plenary talk. I'm going to talk about a bigger, wider view of suicide postvention. I'm a clinical psychologist. I have been in solo private practice most of my professional life. I'm kind of an odd duck because I'm a clinician in private practice, and yet, as Ted mentioned, I do have done a lot of publishing and a bit of research, more kind of trying to be a bridge between researchers and practitioners than having done a lot of research myself. I've been a grief counselor most of my professional life. I came into doing the work around suicide bereavement either, accidentally or karmically, depending on how you look at that. In terms of my own status, I had a great uncle die in 1987 of suicide, and I've had one client early in my career, sort of, who took his life, meaning I was seeing a couple in couples therapy. The couple decided to end the therapy, end the marriage. About 3 months later, the husband took his life, and then the wife came back to see me. So the guy was not in active treatment with me at the time. So I haven't had personal suicide loss up close for myself. What happened is that I had a number of suicide loss survivors in my practice who I was seeing individually, and I had a kind of epiphany that I realized these folks should be talking to each other, not just to me. And so I started a survivor support group in my private practice, which ran for 13 years until I relocated down to the Rhode Island area. That was an inspiration to me. That was a transformational kind of point for me, because I was blown away simultaneously by the intensity of the pain in the room and also by the resilience that you can see in the room that truly is inspirational. And most of the people in this room probably know what I'm talking about. People outside don't understand what that means or what that's about, and they just see it as a depressing work to do. Anyway, I wanted to say something also to all of you who may be clinician survivors. By clinician survivor, I mean somebody who has lost either a family member to suicide or a patient to suicide. And it can be before or after you became a clinician. I want you to take care of yourself today. Coming to a 2-day training on suicide bereavement is likely to be triggering for you, and I want you to do what you need to do to take care of yourself. I also wanted to mention a tremendous resource for clinician survivors, which is the Clinician Survivor Task Force at AAS. And I'm going to turn to my friend and colleague, Nina Guten, who's going to just say a word or two about, a minute or two about the Clinician Survivor Task Force so that you know about it. Nina, do you want to come up and use the mic here, or one of these mics? Are these mics live? You don't have to.
Okay. Yeah, the Clinician Survivor Task Force, I'm one of the co-chairs, exists so that we can support clinicians and other professional caregivers. We're now including people like teachers, clergy, etc. Anyone who's in the professional capacity at the time of a suicide loss. And as Jack said, it includes a suicide loss of a loved one, a family member, a colleague, anyone whose loss has personally impacted you, as well as the loss of a client or a patient, depending on what language you choose to use. The common thread is that the impact is both personal and professional. And so and we recognize that for people who have lost patients and clients due to the confidentiality restrictions, there are very, very few places to be able to process the loss, particularly when lawyers and agencies concerned primarily about liability tell you cannot talk about this to anyone. So what we provide from the task force is a website, and you're going to get that information tomorrow in a handout, as well as an international listserv for clinician survivors who have experienced any type of loss. And so that way people can get onto the listserv, introduce themselves, tell a little bit about their loss, the type of loss, and with a client loss, we just ask that you don't use identifying details, and that way they can get support from people who have experienced the similar types of loss in a way that doesn't violate confidentiality. And if someone is very concerned about that, we can actually use a pseudonym to post for them and still allow them to get the replies. So it's like an online international support group, and at this point we've got almost 400 members on the listserv. On the website we also have a very, very extensive bibliography that's been curated by John McIntosh, who just, the second anything is published, that's related to this issue, he has it up there. We've got sort of test people who have been willing to use their own narratives and descriptives as testimonials for newer survivors. We also have a list of people who, beyond just the listserv, are willing to be live contacts, either through email, phone, whatever, and have their contact information. So we're trying to create a really virtual support network for clinicians for whom discussing all of the aspects of this, both personal and professional, can be very isolating.
And it's tremendously helpful. You can just, if you follow the threads, the email threads that happen, the messages, that's obviously tremendously helpful for clinicians. Okay, can I just see a show of hands? How many people are also coming tomorrow? Would you put your hand up? All right, so almost everybody. So there's stuff that I will tell you tomorrow more about myself and what I'm doing tomorrow that I won't tell you today. So let's see if I can get the technology to work. How many of you know what the National Action Alliance for Suicide Prevention is? Okay, well, one or two people. We need to do more work, Nina. The word is not getting out there. The National Action Alliance for Suicide Prevention is a public-private partnership founded in 2010. It was called for in the 2001 National Strategy for Suicide Prevention. How many of you knew that we have a national strategy for suicide prevention in the United States? A few more hands go up. And it was revised in 2012. And the Action Alliance took charge, set up a task force to revise the national strategy. In both the 2001 and the 2012 iteration of the national strategy was only slightly better in terms of paying attention to postvention. What do we do when a suicide does happen in terms of helping people who've been impacted by that? And so we, through a little bit of advocacy work, we got the Action Alliance to set up a task force specifically for survivors of suicide loss. And I and Franklin Cook have basically functioned as the chairpersons of that. And what I want to talk to you, this document was released in 2015, April of 2015. My understanding is that you have the PDF of the document, the full document, on your thumb drive. So I hope that what I'll do is interest you enough to go and take a look at it more carefully. We put a lot of work and effort into that, the task force, and I think it's a sort of a stealth seminal event in suicidology in America around postvention, because it really is an attempt to say to the field of suicidology and to the larger society, hey, so I'm going to say in a minute, but I'll telegraph it now. Edwin Schneidman, the founder of modern suicidology, is attributed to saying, at least, that postvention, meaning working with people after a suicide, is a direct form of suicide prevention. And I hope by the time you hear my talk, and certainly if you come tomorrow, you're going to be convinced of that. This is a crucial foundational element of all suicide prevention programs, is postvention. And traditionally, postvention, if it exists at all in suicidology, has been the caboose in the movement. And it shouldn't be there. It needs to be given much more recognition, because it's direct prevention work with an at-risk population who we know are at elevated risk for suicide themselves. So what I want to do today is give you a sense of what's in the guidelines, a little overview of it, and then try to talk about some implications of the guidelines for caregivers, first responders, for organizations that are doing suicide prevention, et cetera. So I just said all of this to you. Okay, and I just gave you a background about the National Action Alliance for Suicide Prevention, the National Strategy for Suicide Prevention, and various task forces, one of which was the Survivors of Suicide Loss Task Force. So we drafted guidelines. We had expert review of the guidelines. What I'm doing right now is point number 3, which is trying to disseminate the guidelines. And then ultimately, long range, we want to monitor and encourage implementation of the guidelines. By the way, I said to Sue Eastgard, I'm really impressed with what's happening here in the state of Washington. Washington is one of the handful of states I can point to that is doing a lot of what the guidelines call for already. The kind of programs she was describing, the programs we heard about this morning, are really programs that are what I call the building of support infrastructure for suicide loss survivors. And Washington is leading the way in a lot of ways in suicidology, both prevention in terms of requiring education around suicide prevention, but hopefully also increasingly around postvention. Okay. So just a little bit, I will talk more about this tomorrow, but what do we mean by survivor? One of the problems in the field, particularly in terms of research, is that it's not really until a couple of years ago, in the book that John McIntosh and I published, has a clear definition, operationalizable definition of who is a suicide survivor. What do we mean by that term? It's one of those things that everybody thinks they know what it means, but if you say, well, could you give me a clear definition of who is a suicide survivor? Most people will think about, and it historically has meant the kin, the immediate biological kin of the person who died. And that's pretty much the circle of people who've been seen as targets, if you will, for intervention, for suicide postvention. But hey, what about the kids in school where there's a suicide of a prominent or not prominent student in the school? What about the subway driver who had somebody jump in front of his train and kill himself? He's probably not going to have a grief reaction, but may well have a life-altering trauma reaction to it. That person, under the definitions that are only in the last couple of years have been floated, would be covered by the definition that John and I gave, and also this diagram, which has superseded that, and I actually think is better than the definition that John and I gave. This is a graphic from an article by the lead author in the article was Julie Serrell. That basically is saying that, let's see if I can, oops, I want to go back. That we need to think about suicide survivors as being along a continuum of people. And this includes people who, first of all, who may have been exposed. This is anybody who was exposed to, as we know, not just suicide completion, but suicidal behavior, because that carries risks also. So this could be the subway driver. Okay, this could be a neighbor down the street. This could be somebody who was a follower of Kurt Cobain, and was impacted by Cobain's suicide, even though they didn't have a personal relationship with him. So these are people who have been exposed to a suicide. The next concentric circle are people who are affected by it, meaning they're having some kind of reaction to it. Now, what that reaction is, this outer ring here does not specify. It could be a grief reaction, it could be a trauma reaction, it could be some other kind of reaction, but they are reacting to it. And then the inner circle are the suicide bereaved short term, and bereavement implies the loss of a relationship, separation distress. So it means somebody who is grieving over the loss of a relationship or perceived relationship, okay? So that someone who felt like they were close to Kurt Cobain, even though they didn't personally know him, might be having a kind of grief-like reaction. And then lastly are the suicide bereaved long-term. These are the people for whom the suicide of someone that they know or have had a connection with is what I call transformational. In other words, their life is changed by this, and they do not go back to baseline of who they were before. We know from lots of stuff, including the work that's been done here, that traumatic losses are often transformational in people's lives, not just suicides, but violent, sudden, unexpected deaths, because they so profoundly impact the assumptive world or the belief system of the person, all the things that people took for granted about themselves and their world and their life that have been shattered by this sudden, unexpected, violent death. And then some people's the impact of that will be relatively minor. Notice this doesn't define, well, what does short-term mean? That is something, but it's something that can be operationalized, probably a year or maybe 2 years, something like that. Long-term is somebody whose life is going to be changed, and some of those changes will persist for the rest of their life. These are the people most likely to develop complicated grief. In my opinion, they're most likely to develop a number of kinds of symptoms. They're also the people who, in my perception of I don't know if you know the term post-traumatic growth that's being talked about in the field, which is the ways in which the transformation isn't just about being wounded or diminished by the loss, but also being people growing, wiser, more compassionate, more clearer about their purpose in life, etc. The field is finally getting interested in the ways in which these experiences can be growthful experiences as well as wounding or damaging experiences. And suicide bereaved long-term are likely to be the folks who show the most post-traumatic growth, I believe. That's a testable hypothesis. I believe there's a little bit of evidence about it now. So why should we help suicide loss survivors? Why should suicidology be paying more attention to postvention and people who've been impacted when a suicide happens? The sort of medical model that I encounter all the time says, well, our job that is permeated suicidology as well. We've done our best to try to prevent this suicide. It didn't work, so let's move on. There's nothing more that can be done because the person who's suicidal has ended their life, so the work is done. The next generation of the work has to begin when a suicide happens. So why should we help suicide loss survivors? As I mentioned, Steidman said postvention is prevention of future suicides, paraphrasing him. I think there's abundant evidence now. There's considerable evidence that exposure to the suicide of someone, particularly somebody who we are close to psychologically, and it's turning out that psychological proximity is as or better a predictor of who's going to have the most distress as kinship status is. In my practice, I've known usually it's men who've lost a brother who they weren't particularly close to or involved with in their life, and it doesn't, to suicide, and it doesn't seem to have a huge impact. And then I've seen people who've lost their best friend to suicide, and it's profoundly impactful. So kinship, while it's certainly a marker of psychological proximity in most cases, psychological proximity itself is a better marker of who's likely to be distressed than simple kinship status. So there's abundant evidence, and I'm only going to summarize it here. I'll share a little more of it with you tomorrow. Bereaved parents who are bereaved by suicide, particularly mothers. All these folks are people who are at elevated risk for suicide themselves after they've been exposed to the suicide of someone important to them. Second is bereaved spouses, particularly older males. One study I read from a very good population-based study from Denmark found that, if you're an older male and you lose a spouse to any cause of death, there's about a 10-fold increase in the chances that you will die by suicide yourself. Because bereavement is one of the catalysts that, and one of the sources of psychological pain that triggers suicide and suicidal thinking and behavior. So if you lose your spouse to any cause of death, there's a 10-fold increase in the chances that you will die by suicide. If you lose your spouse to suicide and you're an elderly male, there was a 46-fold increase in the chances that you will die by suicide. Talk about a high-risk population. Elderly males in the United States, it's mostly been Caucasian males. It was my great-uncle. My great-uncle had lost his wife 6 months earlier of many, many years. He was fairly estranged from his only child who lived in another state. He lived in a small town in western Pennsylvania. Most of his friends had died. He had just been diagnosed with cancer, and he had a firearm in the house. Now, his wife did not die by suicide, but he fit the profile to a T of people who historically in the United States have been most at risk for suicide. Elderly, isolated Caucasian males who've had recent losses and or have received a recent diagnosis of a life-threatening illness. But if the spouse died by suicide, elderly men are particularly at risk. Bereaved children, particularly if their parent, particularly their mother, has died before the age of 21, have elevated rates of suicide. And you might say, well, isn't some of this shared genetics? Probably it is. But the elderly male who loses his spouse to suicide, presumably there's no shared genetics there. One of the things I want you to understand that the guidelines are trying to get us to pay attention to a wider circle than just the immediate kin is that lost the thought. This is what eating and then having to get up and do a presentation does. A wider circle than just the immediate kin is that exposure to suicide, I'm going to go out on a limb here and make a kind of a bold statement. I'm coming around to thinking that we need to think of suicide as contagious in the same way, and it isn't just contagion among young people, which that language has been used, public health language has been used for a while. We need to think about exposure to suicide as exposure. The public health system in America is very concerned with the spread of Zika virus and with HIV virus, et cetera. We need to be concerned about the spread of the suicide virus, if you will. Because I think, again, there's abundant evidence that exposure to suicidal behavior in other people, it's kind of catching. There's a role modeling effect, is another way of saying this, that the field really has not paid enough attention to. More than in the past, but not enough. There's even a study in Denmark, I believe, that in a workplace setting in which the setting is relatively small, meaning there's less than 100 people that work in the workplace setting, and there's a suicide of a person in your workplace setting, there's a 3.5-fold increase in the chances that someone else in that setting will die by suicide. So exposure in a workplace setting. How many postvention efforts have been devoted to workplace settings and reducing future suicides in workplace settings? In case you haven't figured out yet, at one point in my life I thought about being a preacher. You can ask my kids if I can preach or not, okay? So my seemingly scholarly lectures are really disguised sermons. All right. And I could have done a pretty good fire and brimstone also, I think. All right. And then certainly we know that peers in young adolescence and young adulthood, the military is struggling with what is appearing to be a suicide contagion within the military, which is, after all, the military is mostly made up of young people, young adults. All right. So in addition to this elevated risk of suicide that comes from exposure to the suicide of someone else, there's a whole lot of other complications that we know about that come. Sid's excellent presentation this morning pointed to some of them, but the data suggests that there are elevated rates of mood disorders, substance abuse, isolation and stigmatization that results from stigmatization, complicated and prolonged grief. And in a study that I was part of that Bill Fagelman really was the lead person on, we've seen effects of exposure to suicide, elevated rates of suicidal ideation in parents who've lost a child to suicide 10 years later. And Sid's study this morning indicated that there were elevated rates of suicidal ideation. I was delighted to hear that the complicated grief therapy also may be efficacious about bringing that suicidal ideation down. That's very good news for the field. So this is a long-term negative set of sequelae that result from when a suicide happens. And we need to be taking, and are beginning to take, a public health approach to this. Historically, suicide has been considered just a sort of something that either a crazy person or a very selfish or sinful person does, and maybe from a crazy family, but it doesn't have anything to do with the rest of us. You know, we just don't talk about it, and it's just a crazy person, and just sort of wall it off. This is shifting around the world, not just in the United States, to a public health approach which says, no, this affects all of us, and there are things collectively that we can do to bring down suicide rates, and part of them is developing good postvention. All right, excuse me, suicide leaves considerable collateral, what a client of mine once called the collateral damage of suicide, in its wake. Okay. So what are some of the recommendations? Let me just briefly describe the organization of the guidelines. And again, I encourage you to go and read them for yourself. It's organized around 4 strategic directions that the National Strategy for Suicide Prevention was organized around. We borrowed those 4 broad goals or directions for the postvention guidelines, which were, first one is healthy and empowered individuals, families, and communities, how to create that. Second is clinical and community preventative services, how do we prevent suicide, or how do we prevent some of the collateral damage from after a suicide. 3 is treatment and support services, which is this basically models the old public health tripology, I guess you would call it, of prevention, intervention, and postvention, but also primary, secondary, and tertiary intervention. Treatment and support services, and then the 4th is we have a section on recommendations for research on suicide, postvention, and bereavement. There are a total of 15 goals and numerous objectives under each goal. I'm going to show you one of them in a minute. And then there are 3 appendices in the document also. It's got some meat on the bones, the document. So let me give you one example of a goal and some sub-objectives in it. Goal 4 is to create the infrastructure and delivery systems for training a wide array of service providers in suicide bereavement support and treatment, and in minimizing the adverse effects of exposure to suicide. And then under each goal there are objectives. Objective 4.1 is offer training and support for service providers that covers all levels of care and is based on best practices and evidence-based models. Objective 2 is provide customized training and support in responding to suicide loss survivors. Yes, there are things about responding to traumatic loss that go beyond just suicide bereavement. Probably most of the ways in which a compassionate, caring response by first responders that they would make to suicide loss, to a suicide loss, also would apply to homicide loss and accidental deaths. But there are some things that are unique about suicide that need special attention, and that's part of what we're calling for here. And then Objective 4.3, include in all levels of education and training curricula for service providers, such as licensing certification and job-related requirements, clear, quantifiable mandates for evidence and skills-based instruction in suicide bereavement care and in minimizing other adverse effects of exposure to suicide. So that's an example of one of the 15 goals and 3 of the objectives that comes under it. I'm obviously don't have time, and I'm not going to go through all of the goals and objectives here. That would put us all into what somebody in an audience of a training I was doing once called a food coma, which is what happens after lunch when you have to come back for the afternoon part of the training. Okay, so I'm going to talk now about implications for different categories of caregivers. Mental health clinicians, when I say clinicians, I'm essentially talking about mental health clinicians. I'm going to talk about first responders. I'm going to talk about organizations. So what are some of the implications of what the guidelines have to say? Not just that one goal, but the overall guidelines have to say, for example, for mental health clinicians. First of all, we want you to understand the elevated risk for suicide and other complications that come with exposure. How many of us routinely ask people about their exposure to suicide over the course of their lifetime? Julie Searle's research suggests that about half of the U.S. population at some time in their life will know somebody who will die by suicide. And about 2/3 of the population will know somebody who has died by suicide or made a suicide attempt. And so we got 2/3 of the population who's been exposed to this suicide virus, if you will. Not everybody, obviously, who is exposed to a virus develops the manifestation of the problems or the illness. But it's important, if you're thinking about this in a public health perspective, you've got to pay attention to the numbers, the huge numbers of people who are exposed over the course of their lifetime. Study by Crosby, I forget his first name. Ted, you gave me the name for it. It's dysnomia? I said, oh, he knows what I've had for the last 5 years, and it's getting worse as I get older. Dysnomia. Now I can impress all my friends, No, that's just my dysnomia. Don't take it personally, So we want people to understand that exposure carries risk with it. We want you to understand that the impact may go far beyond the immediate kin. And if you have, particularly if you're in an organization, don't just be thinking about, what about the brother, or what about this kid's closest friends? What about kids in the school who didn't even know this person, but are thinking about suicide themselves? And they've been exposed to the role modeling impact of suicide, even though they aren't directly bereaved in the sense of grieving the loss of this relationship. We've got to widen the circle of the impact of suicide. Get training in working with suicide loss survivors. The training tomorrow is an effort, I'll say this briefly, is an effort by the American Foundation for Suicide Prevention and the American Association of Suicidology to develop a suicide loss specific training for mental health professionals. It comes out of work that I've been doing for a while, and we're beginning to, we rolled it out this year, but I'm already beginning to train a small elite subset of people who are going to be learning to deliver the training, and then we're going to expand that to more people. Also, something else that is built into what we're trying to do here is clinicians who take the training and voluntarily choose to do this can enroll in an online database that AFSP and AAS are creating so that survivors, when they look for a clinician, can have some rational basis for finding a clinician. Lori Burke was telling me at lunch that she applied to an insurance company to be a provider and try to emphasize her credentials, her skills as a highly experienced and knowledgeable grief therapist. And they said, oh, well, we already have all the grief therapists we need. And she sort of said, what? And wrote back, said, well, we have, 273 grief therapists in our panel already? I don't think so. I mean, what you have is 273 people who checked the grief box on what things do you do in your practice, because most clinicians will say, oh, sure, I do grief. But I give this as an example, a horror example. I had a woman come to me early in her grief who'd lost her daughter to suicide. And after 3 sessions, the clinician said to her, you're dwelling on this too much, and wanted to start doing cognitive behavioral therapy with her to change her negative thinking about stuff. I didn't know the clinician, I didn't know them at all. All I can tell you is that clinician, a benevolent way of looking at it would be that she was clueless, that she had no idea what the territory looks like to tell a bereaved mother new in her grief, you're stuck on this, you're dwelling on this too much, let's move on. And I have tools to help you move on. All right, so get training in working specifically with suicide bereavement. I think there's much overlap in working with other kinds of traumatic losses, although again, there are some aspects of suicide bereavement that make it, I don't like the word unique, but are going to be more prominent in suicide bereavement than in even homicide survivors or in accident loss survivors. Okay, provide services for survivors if you can. Lori's doing restorative retelling in her private practice in Portland, Oregon now. That's great. That's what I mean by building support infrastructure, including trained clinicians who are offering services specifically for traumatically bereaved people and suicide loss survivors. I started a support group in my practice because of what I saw. Help survivors connect with other survivors. Peer-to-peer stuff is not for everybody. Not everybody will go to a bereavement support group. Not everybody wants to talk to other people going through this, but a large percentage of people tell us they do want this, and some people tell us literally, that group saved my life. Talking to other peers literally saved my life. I wouldn't be here today if I hadn't found that group. And so connecting survivors with other survivors, that peer-to-peer principle is so valuable for so many people, and mental health professionals need to get over the idea that only they can provide the services that are needed. I think we are losing that. I think there's a growing respect for peer-to-peer, the value of peer-to-peer work and collaborative work with peer-to-peer approaches. Okay, so what does this mean for organizations? And I'm talking about schools, workplaces, and then I'll talk a little bit more about what does it mean specifically for suicide prevention programs. How am I on time? All right, I stop at 2:45? Okay, I talk pretty fast. I don't have to talk so fast, do I? I thought I would have to talk fast. What does this mean for organizations, schools? Again, I would go back to what Sue presented this morning. First of all, have a plan. Be prepared. Have a plan for how your organization is going to respond. First of all, when someone dies in the organization, and then when someone dies in this particular way after a suicide. And there are lots of good examples. Sue was pointing to one of them, the SAMHSA guideline. AFSP has an excellent toolkit for schools that's free and downloadable about how to respond when a suicide happens in your school setting. Have a plan for how you're going to respond. Provide specialized training for appropriate staff in working with suicide bereavement loss. Doesn't mean that every human relations person in your company has to be trained in this, but have somebody in the group who has some special skills and knowledge and training about dealing with this and assessing it. Provide resource information to everyone who is exposed. I cannot emphasize this enough. Some of the research that Kari Dyregraf and her colleagues in Norway have done suggests that, and some stuff that research that I was involved in kind of substantiates this, corroborates it, is that the first year or two for a family that has been walloped by a suicide of a family member, people are stunned. They are hunkering down. They're in a kind of cave, dealing with their grief, their depression, their trauma. And the idea that they have to mobilize themselves to go out and find a suicide support group, to find a therapist who can help them, that has some skills and knowledge, is really daunting. And one of the programs I'll talk about later, the LOSS program from Frank Campbell's program, has some data now that Julie Serrell was involved in, also showing that people who get a visit from the LOSS team is an outreach team that goes to survivors, goes to the scene actually of the suicide, rather than people have to come and find support for themselves. That it about cuts in half the amount of time it takes for people to then follow up with access some additional services. That's a huge reduction in access time, to cut it in half. And we see this also at Samaritans. We have an outreach team. It's not a LOSS team, but it's an outreach team that will meet with new survivors. And our sense is that this gets people into our support groups more quickly. The outreach team serves as both a normalizing experience, an informational experience, and also a bridge to get additional resources and services. But I can't emphasize enough the importance of telling people where they can get more help if and when they decide that they need that, instead of leaving it up to the family or the individual themselves to start searching around for it. Identify and reach out to highly impacted individuals in organizations or groups that have been impacted by suicide. So as I mentioned earlier, in a school setting, it isn't just the kids who were the close friends or the girlfriend or the boyfriend of the adolescent that took their life. It's also other kids who may have made previous attempts, or who you know are suicide loss survivors, or who've been depressed and thinking about suicide themselves. Those folks are all at elevated risk now. And so you have to do some work to identify who's likely to be particularly impacted by this and do proactive outreach. Could be eyewitnesses to the suicide, could be people that had psychological proximity or closeness to the deceased, and it could be people who are already depressed, suicidal, or have made previous attempts. What does this mean for continuing that theme for organizations? Use the suicide as a teachable moment. There's enormous amounts of misunderstanding and misinformation and ignorance really about suicide and what contributes to it in our culture. And so people have all kinds of myths in their head. Suicide is just sinful behavior. You have to be crazy to commit suicide, et cetera, et cetera. Let's use it as an opportunity to educate the community about what leads to suicide, alternatives that people have if they are feeling suicidal themselves, and things that people can do that are healthy forms of grieving, such as getting involved in suicide prevention efforts, or raising money for suicide prevention organizations, or getting involved in peer-to-peer counseling, etc. There's a tendency, there's a fear, misguided as far as I understand, because there's not a lot of good evidence about this, but a misguided kind of urban legend that the only way to deal with suicide when it happens in for example, a school setting, is that you have to stamp out any kind of memorialization. Otherwise, you're going to have wild, uncontrolled contagion happening in the school. I heard another horror story about I wasn't involved with this setting. This is a colleague that told me this. A school that he had heard about in which a teacher had taken her life. And what the principal did is the principal called all the teachers together and said, here's what we're going to say to the students. When people ask, well, where's Mrs. Smith? What happened to Mrs. Smith? Your response is to be, and he was issuing an order, your response is to be, Mrs. Smith doesn't work here anymore. That's it. That was the extent of the postvention response. There's also, remember, that people in the Middle Ages who took their life, the body was often taken out and drawn and quartered. It was publicly meant to be demonstrated as this is sinful behavior, this person is going to hell, and the family was often punished. In other words, the family was punished for the quote-unquote sins of the person who had taken their life. And that kind of angry, punitive response to suicide still exists in the world. And some of it is masked as tell people that Mrs. Smith doesn't work here anymore. I know nothing of the facts of this, but that doesn't stop me from speculating. I wouldn't be surprised if that principal or superintendent was furious with the teacher. And so this was a kind of angry, punitive response. We're going to wipe her off our memory banks. Okay, so use suicide as a teachable moment within the organization. About suicide, about where to get help when one is suicidal or having a hard time, about grief and trauma after suicide, and about appropriate responses to the bereaved. One of the problems the bereaved face is that nobody knows I call it social ambiguity. Nobody knows exactly how to respond when a suicide happens. So if you've been sort of good friends with a neighbor, but you're not that close, but you wave to them, you talk to them over the fence in the summer, etc. You find out that their son has killed himself in the house. A lot of people are going to be like, what am I supposed to do or say? Can I use the word suicide, or is it better not to talk about it? Do we send flowers? I'm not sure what to do. People avoid suicide loss survivors not simply because they're an outright condemnation or stigmatization of it. A lot of it is just awkwardness. They don't know what to say or do. So if all of us, if we face a social situation in which we're unsure of what the rules are of appropriate social behavior in that given circumstance, what do? We avoid it. We don't talk about it. We avoid the people. And survivors will tell you, most survivors have stories about people who they've known, who they thought would have been there, who turned and walked the other way when they saw them in the supermarket, or would be around them but wouldn't use the word suicide or talk about it, mainly because they're embarrassed or it's awkward or they're uncomfortable. So people need education about what's an appropriate way to respond when someone dies by suicide. The answer is the same way you would respond if they died of any other cause. Express compassion, empathy, condolences, and support, and offers of help in the same way you would after any other kind of loss. This is changing in our society, I believe, but we have a deep legacy of shame and stigmatization that still surrounds psychiatric disorder and suicide. Okay, provide psychoeducation and peer support activities for people, and then follow up longer term. I was glad to see that Sue's protocol talked about following up longer term. So much of the postvention efforts in schools and in other organizations is very short-term and crisis-oriented. The model is crisis is short-term, you get people back to baseline, and then you go on about your business. I much prefer, and tomorrow I will talk about this in terms of my model of doing therapy, but I prefer that postvention efforts be extended. Not that you have to be being there every week in the school or something, but around the anniversary, there's going to be an upsurge of people remembering and feeling stuff. And how many postvention programs go back a year later around the anniversary and do some more follow-up work? Extremely rare and extremely progressive if you find that. This isn't a short-term event, and people don't get over it quickly who've been really impacted. Certainly most of the people in the school will be over it and okay, but the people who are deeply impacted a year later are going to have an upsurge of their grief and their trauma. The AFSP toolkit I've already mentioned. Okay, what does this mean specifically for suicide prevention organizations and programs? I can't emphasize this enough. Sorry, let me go back, get the magic dot here. Always, I should add a couple of more always here. Always, always, always include postvention programming and planning in your prevention planning. Please don't make postvention the caboose in your suicide prevention program. Not just because postvention is the right thing kind of morally or ethically to do, but because it is an proactive form of prevention of future suicides. Second, work towards a coordinated community response. I'm going to, a little bit later, in my presentation tell you about something that I'm involved in the city of Newton, and that we're trying to get started in the Commonwealth of Massachusetts around developing a coordinated response to suicide. So much of what happens is the right and the left hand not talking to each other. The funeral director doesn't talk to the police don't talk to the clergy person. Now in small towns you see that happening because of the cross-joined social networks in small communities. But in large urban areas, that just never happens. People come in, do their little piece of the job, and then they leave. And then they're on their way. And we are arguing for, and there's a service in Australia that I'll tell you about in a little bit, that it's beautiful at how it is doing this kind of, fostering this kind of integrated community level response, coordinated community response to suicide. Actually, by the way, this can also be happening after any traumatic death. You could have the same kind of principles guiding a homicide survivor program in the country. These are not just principles for suicide loss. For example, develop a lead agency within the state and within the community who's in charge of coordinating the response, the community response to suicide. Develop coalitions, suicide prevention coalitions. Usually suicide prevention coalitions in local and state level have a large number of survivors in them, and so people are interested typically in postvention, not just in prevention, or they see the connection between the two. Bring first responders, EMT, police, fire, rescue, mental health, clergy, funeral professionals, educational and medical people together to plan how to work together. Let me just briefly tell you about the standby service in Australia. Basically what the standby service does is it initially goes into a community when they've been invited by the community and does community organizational work. They will bring all these players in the drama that get activated when a suicide happens together and say, how can we work together better around responding as a community to suicide? They will help the group develop protocols about what will happen. They also help people develop a lead person that is put in charge when a suicide happens, so people know who to contact. Whether you're clergy or police or fire, it's cross-disciplinary about how to respond. And what they also do, which is I think a terrific idea, is they have somebody who is designated to become, in essence, the ombudsperson for the family. They will meet with the family and they will talk with the family about how they're doing and assess what they need, and they will stay with that family for a year, 2, 3 years, checking up on them, following them, okay? Now, they're not a therapist per se. They're serving as an ombudsperson. They will help them get connected to a lawyer if they need it, help them get connected to a mental health professional if they need it. Guess what? They've done research now that not only shows that people that get the standby service as opposed to communities where they don't have it, that people do better, have less complicated grief, et cetera, as you would hope for and expect. But they, to the best of my knowledge, they are the first postvention program, maybe the first bereavement program, which has demonstrated an economic offset. They found that it actually costs the community in the long run less to do this kind of standby intervention service than communities that don't have it. If you follow up all the extra medical visits that happen, all the extra things that extra services that people may access, or the deeper trouble that people get into before they get into services. So it really is prevention of all kinds of sequelae, including hopefully suicidality, by designating a person who works with that family for an ongoing longer-term follow-up, not just a crisis intervention response. I love the program. The woman who's founded the program is retiring, but I hope to get over there and get trained in it and see actually what they do. I've only read about it, and I've talked to her sometimes about it, about what they do. I think that's a beautiful model of what I'd ideally like to see. The guidelines were influenced, because I was one of the co-chairs of the guidelines, are influenced by this model of a community-level response to suicide. Develop informational resources that are local and specific to that locale. Develop coordinated referral process. Develop outreach teams, and I'll talk a minute about the LOST team and some other examples of this. What is continuing that theme of prevention postvention programs ensure that families and others who have been impacted receive information about suicide, grief after suicide, trauma, and where to get help, information about how to access resources, screening about risk for suicide. That should be a routine part of early intervention with folks. Both psychoeducation about elevated risk for suicide. I've never sat with a family after a suicide, close in after suicide. I don't typically see families immediately after the suicide, but relatively close in, that if you sit with the whole family, you will always find somebody in the family who's worried about somebody else in the family now being suicidal as a result of this. We're worried about mom, how she's going to deal with this. We're worried about grandma. My dad's been depressed anyhow and he's got a drinking problem. I'm really worried about him. That kind of risk assessment is really important to prevention work. Follow up with the family, and in addition to suicide prevention, offer or refer to focused treatment for complicated bereavement and or trauma support. Complicated grief, by the way, is not traumatic grief. Sometimes those words get used interchangeably, but complicated grief is in essence unremitting yearning that doesn't remit over time. As Sid was saying, it's grief that is stuck, but it's yearning. You could develop complicated grief if your great-grandmother died peacefully in her sleep at age 97. Complicated grief is about the reaction to the separation from the loved one. Traumatic grief has to do with the way in which, the mode of death, the way in which the person died. And traumatic grief to me is the fusion often of complicated grief and of post-traumatic stress disorder. Provide specialized training around trauma, risk assessment, and suicide bereavement management to appropriate staff, et cetera, first responders, clergy, and funeral professionals, primary care physicians, et cetera. The guidelines also call for the development of support infrastructure, peer support activities, support groups, fundraising walks. Samaritans in Boston, where I consult, we do fundraising walks, and so does AFSP, national walks. But those are survivor gatherings. Those are healing conferences masquerading as fundraising events. And they are fundraising events, obviously, but there are opportunities for survivors to talk to other survivors about their experience. Online resources are beginning to really develop. Nina mentioned one for clinician survivors. There's some excellent online bereavement support resources for suicide loss survivors. Any kind of peer support activities that you can help foster in your community are going to be valuable. Develop mental health infrastructure, which means trained and experienced mental health clinicians, trained in dealing with trauma and complicated grief, and ideally suicide bereavement. I think it's a great idea to partner with other groups in your community that are working with traumatic loss, such as homicide survivors, like the separation services here at Virginia Mason. But other organizations that are kind of balkanized, even though there's a lot of commonality and overlap in the grief response. And Sid's study suggested that there was a lot of overlap and commonality in the way in which people responded. All right, what does it mean for researchers? I'm gonna. Any researchers in the audience besides Sid and Ted and Lori? Lori, you know this stuff already. I'm gonna skip through this. Read the guidelines. There's a whole section and Bob actually and Julie Searle and Miff Maple just sent in to me. There's a special issue of death studies that's gonna just be dedicated to the guidelines. That if I ever get my act together, will get done. That has a whole section, a paper that Bob and Julie did on research recommendations for researchers interested in suicide bereavement. I'm going to skip through this because I want to leave some time for questions or reactions, and just may give you a couple of examples of the kind of guideline implementations. I mentioned the programs here in Washington that I'm impressed with listening this morning. In Massachusetts, there's a group of us who are involved in the guidelines, who have formed an ad hoc committee that is basically working with one community, Newton, Massachusetts, where they've had a number of suicides of adolescents and young adults, around trying to create an organized community response. We're trying to do what the standby service does, and we're sort of flying by the seat of our pants about it. but we have developed a training that is specifically cross-disciplinary for early, not just first responders, early responders. So that includes mental health professionals, clergy, funeral professionals, EMTs, et cetera. And we're going to try out this thing about training people in suicide loss response across disciplines, rather than assuming that each discipline needs to be trained just by people in its own discipline, only about the narrow job that they do. It's an effort to try to create this kind of cross-joined collaboration within the community. And if it works well, when we refine it, we'll start trying to do it in other communities in Massachusetts. Survivor outreach programs. This is one example of the lost teams. Frank Campbell, pioneer in the field, worked for years in Baton Rouge, Louisiana, both to develop a crisis intervention, essentially a bereavement support program for suicide loss survivors, and also worked for years to get the police and the medical examiner to allow trained volunteers to come with the police and medical examiner to the scene of the suicide to provide support, information, and also initially the police and the medical examiner were quite resistant to this. It took them many years to get them to trust the program. They now love it because what happens is that the police can do the work they need to do. The volunteers on the lost team always consists of a trained suicide loss survivor and a mental health professional who go as a dyad, meet with the family at the scene of the death or wherever the family happens to be, but it can be in the home at the scene of the death. They explain to the family why the police are doing what they're doing, and the police love it. Then the family is not bothering them, and they act as a go-between and a buffer between the police and the medical examiner. Frank is now, like, I call him the Johnny Appleseed of suicide postvention. He's planting the seeds of lost teams literally all around the world, but both around the United States and in other countries, and helping lost teams get started all around the country. Superb idea. At Samaritans, we have something that we call the Survivor-to-Survivor Network, which are trained lost survivors who will go out and meet with families at their home. We do not go to the scene. It's not a lost team model. We have to be invited to come in. But we will see people for up to 6 times in the course of a year. So what often happens is one person in the family, often, for example, a wife or a mother, will ask for a visit from the SSN team. We go, and then she says, hey, this was great. Would you come back and talk to my husband? So we go back another time and talk to she and her husband. Then we might talk to the kids in the family. So it's a kind of availability. And again, they have to find us in the sense they have to know that we exist, but we go to them. They don't have to make an appointment and wait 3 weeks and go to a clinic and sit in a waiting room and all that kind of stuff. We come to them. That's why I call them outreach teams. Survivor gatherings. AFSP for years has had what's now called International Survivors of Suicide Day, the Saturday before Thanksgiving, every year. It happens in I don't know how many, probably 100 countries around the world, and all around the United States now. There are gatherings of survivors that watch a video that is terrific. I've seen the preview, the one that's coming for this year. It's just superb. It's with long-term survivors, people who are many years out, talking about both what it was like for them in the beginning, but also offering hope about healing and recovery and what that looks like to new survivors, because it's mostly new survivors that come to these events. You can find out about this, by the way, if you go to the AFSP website, where there's one happening in the Seattle area. At Samaritans in Boston, we do an annual memorial service that's open to any survivor, another form of survivor gathering. And then I mentioned fundraising walks are actually also kind of giant support groups for people. I just came from a retreat that AFSP led in Chicago, 5 minutes, okay, that's basically was for long-term survivors, which was an amazing experience. Both the simultaneity of people's ongoing grief, the wound is still there, and the healing and the recovery that has happened in people. So I'm getting the 5-minute sign. Let's see if we've got any questions, comments.